Good evening. On behalf of Sutter Health, welcome to tonight's session on knee and hip pain. If your joints ache, you've come to the right place. The orthopedics program at Novato Community Hospital and California Pacific Medical Center are some of Northern California's best. Tonight, we'll learn about joint pain treatment options from Dr. Peter Callander. He'll share a great presentation and answer your questions live at the very end. We're very grateful for this webinar technology so that we can be with you here tonight. So just a quick matter of business on how an online webinar works. We can't see or hear you, so when you have a question for the doctor, anytime during the presentation, scroll your mouse or pointer over the screen and you'll see a Q&A button at the bottom. Just click Ask a Question and type it in. Dr. Callander will answer these questions at the end. And once the webinar is over, a survey referral form will pop up on your computer. On the form, you can ask more specific questions, give us feedback about the webinar, and schedule a consultation with Dr. Callander if you're interested. And in case the form doesn't pop up tonight, we'll email it to you tomorrow, so you'll have it. Well, enough of the formalities. Let's get on with the show. Tonight, we're lucky to have with us Dr. Peter Callander. He's an orthopedic consultant to the San Francisco Ballet and recognized as one of the top orthopedists in the country. He specializes in hip and knee replacements, orthopedic surgery, and surgical arthritis, with an emphasis on minimally invasive techniques. Dr. Callander is a recognized national leader in anterior hip replacement. He graduated Stanford University, received his medical degree from St. Louis University, and completed his orthopedic surgery residency at UC Davis. Dr. Callander then completed a fellowship training in hip and knee replacement surgery at Cornell University in New York City. He has performed thousands of hip and knee replacements, countless complex reconstructive surgeries, minimally invasive procedures, and treated many others with non-surgical options. But most importantly, Dr. Callander's patients have some of the most exceptional outcomes, and they live without pain. And despite a very busy schedule, we're glad he could make it here tonight. So with that, welcome, Dr. Callander.
Thank you, Sean, and welcome everyone. Thank you for your kind words, and delighted that all of you could join us this evening for the webinar. As we get started here, I'm going to do our Zoom work and share the screen. All right, welcome everyone. So again, delighted to have all of you here. And the concept of tonight's presentation is really to give you all a background of what does it mean to deal with sore joints, how do we deal with them, and what are the treatment options. And so I want to kind of go over with you the idea of building on the treatments for sore joints. What can I do conservatively? And when all else fails, what do we do from a surgical standpoint? And so I am going to focus a little bit more on the definitive treatment options, because a lot of us understand, we've tried all the conservative options, and if they fail, then what are my options when it comes to surgery? And so what we're going to talk about right now is a little bit about how can we beat that old age with new joints. And so as Sean alluded to, my area of specialty is joint replacements in hip and knee, and I've been doing this for over 20 years. And so I've seen everything and seen how it's changed. And so that's really the exciting part of all this, is being able to share with you how the technology is advanced. And that makes it very exciting for me. So I want to share with you that passion, and we're going to move forward and go from step fashion from hips and then into the knees. So let's begin. And I love to use the analogy of the car, because as we know, we all drive our cars, and as the cars get going, the tires start wearing down. And this is a great cartoon of where we say it makes a cracking, popping sound every time I get in and out. And the mechanic says, well, that's just your knees, sir. And of course it is, because as the car drives along, it starts to wear. And if you think of it as the tires wear down, and then that is your joint. And when the tires wear and you're riding on the rims, that's when you're riding on the bone, and it's bone on bone, and that tends to cause the pain. And so, what are the symptoms that you experience when you start feeling these aches and pains in your joints? And some of them are you'll feel that it's warm to touch. You might even find that you'll experience some swelling, maybe even some pain and immobility. You can't get up from a chair like you used to or run down the block. Your activity will decrease and your overall lifestyle changes. So you can't keep up with your friends or do the things that you like to do. And so sometimes when you see that you're starting to have these aches and pains, you might even see that you'll see some changes in your alignment. And so if we look at this top picture, you'll see that you're a little bit bow-legged, and down here you can be knock-kneed. And that's because the joints change. They tend to wear on one side or the other or on both sides. And when you see that, you'll see that you'll ache on the inside or the outside. And this can continue to wear. And when you do have this bone on bone, that leads to pain. So, what are some of the treatments? Well, the conservative options are such like anti-inflammatories, we call NSAIDs, non-steroidal anti-inflammatories, like Advil, Aleve, Motrin. Sometimes we also consider just taking Tylenol. If that doesn't tend to help, we find that physical therapy is a super option to try, because the idea is that when your joints become bone on bone, they also become tight and swollen, and getting into physical therapy can really help to loosen up the joints. And when you get that mobility back, that can also help with just minimizing the amount of pain that you'll have with your daily activities. Thirdly, steroid injections. You probably have had friends, or maybe you have already had episodes where you've had sharp pain and you end up having a steroid. And that is very helpful. I see that a lot with my athletes or people that you need to have instant relief. Perhaps you're going on a trip and you want to get some relief for the trip, understanding that down the road you might need to have something more definitive done. Weight is always plays a role. So getting weight off will definitely help you with getting the pain to subside. And then if all of these conservative options fail, then the final option is surgery. And that's what I want to focus on with you tonight. So the main thing and the reason why we're here is I want to let you all know is that the experience that a patient has when you come to the hospital with need for a hip or knee replacement, it has changed considerably. And it has changed to a point that it really has reached a point where you almost could, show up, have your hip or knee replacement done, and then return home in time for dinner. I mean, it's getting to that point. And in the old days, we used to have very long incisions, a lot of blood loss, a lot of pain, your nausea, everything. And it was a horrible experience. Now, the experience, I'm not going to say it's a spa day, but it's definitely a day where you're going to come and go and get the job done, and you're going to get it done with the most advanced technology, state of the art equipment, and everything else. And so that's what I want to show you here. So what is new? As I said, it's a shorter hospital day. Sometimes we're doing hips and knees on patients depending upon their health and what the underlying deformity is. You may even go home the same day or in 23 hours. Why is that? Some of the reasons is that now when we do our surgeries, you don't end up having a general. 98% of our patients usually have what we call a block or regional anesthesia, where we put your legs to sleep for a hip or knee replacement, and you don't need to have a full general, because when you have a general, you end up having to wake up and you're a little bit out of it, and you may even have some nausea or maybe even some vomiting, and that's no fun because that slows up your overall time to get home. So we want to shorten that stay and make it as painless as possible. So that leads to a quicker recovery. And we all want to have a quick recovery. Why? Because we got to get home, we got to get back to work, we got to take care of the kids. And so we understand that, and that's why we customize your visit to meet those needs. The other way we do this is that incisions now are much smaller. So we have 4, 6, inch incisions for hip replacement. Same with knees, much smaller. When you have smaller incision, less trauma to the soft tissue, less blood loss, again, a quicker recovery. And as I said before, less nausea and vomiting if we are able to control your pain with medications that don't have the side effects that we used to have with such as like morphine or Dilaudid, really heavy IV drugs, we tend to stay away from. And we can do that because we also give you medication through IV or into the tissue where we're doing the surgery, and that helps to control the pain. Finally, it's really a concierge approach. You come to the hospital here at Sutter, and as I said earlier with this idea, and again, Sutter, we're looking at CPMC or Novato, both are advanced facilities, but we're both looking at this as a team approach. And so everyone understands your specific needs and your specific background so that we meet those needs and we make sure that when you come through, your physical therapist, your occupational therapist, your nurse, your surgeon, everybody knows exactly who you are and why you're there and how we're going to make this a perfect stay. So moving forward, I want to tell you a little about the advanced technology, but before I forget, I wanted to say one thing, and that is what's so great about Sutter is that they have two very advanced facilities. The one in San Francisco, where it's a completely new building. I call it the new St. Luke's. It's the Mission Bernal campus, where it has a state-of-the-art facility with private rooms. Everything is really VIP from the standpoint of the facility, as well as the protocol. The same is seen in Novato. Again, private approach with your rooms and the facility and the technology. You also have to understand is that the surgeons who take care of you are all fellowship trained. So they're all advanced. They all know their specialty to the degree that is their own little niche. So you're going to get your shoulder done, you're going to get it done by a shoulder surgeon. You get your knee done, it's going to be a knee surgeon or a hip surgeon. So that's very, very important to understand. You're not going to get a generalist, and you're also going to get the most advanced technology. All of us are on various committees and advanced review sessions and so forth that allow us to understand what's the latest and greatest, and we bring that here to San Francisco. The other thing is that our facilities are advanced facilities from the standpoint of being an advanced certification for total joints. So we have been qualified as a place that if you're going to get your joint replaced, you want to do it here at Sutter. Why? Because they have met the protocols and they have also met the high standards that are required to get an advanced certification. So understand that. Now, when we get into the whole process of the procedure and the joint replacement, thing to understand is that we have advanced technologies from the standpoint of instrumentation, state-of-the-art ORs with operating room tables, which I'm going to talk about shortly. The designs and the materials and the techniques that we use are all very advanced. We also do 3D printing and we use robotics. So we'll touch on all of that during my talk here with you today. So let's start at the top and we'll start with the hips. And I love this cartoon where the patient comes in, physician recommends a hip hop replacement. And that's what we're going to do. And we're going to hop right through it. And the first thing I want to talk about is if you look at this X-ray on the left of your screen, you'll see that this is a hip replacement. This is a hip joint. And if you look at the hip joint, you'll see that the head is nice and round. And it also has a lot of space in between the ball and the socket. And that's a good hip because you've got a lot of cartilage in there, okay? When you look at the right, you'll see that the socket is worn down a little bit and there's less space and there's white in there because that's what we call sclerosis. You have flattening of the femoral head. And so when that happens, you have pain. So again, returning to the analogy of a car, the tire on the car is worn down and you're now riding on the rims. And so that's what we're seeing here is you're riding on the rims and you're getting a square peg in a round hole. and you're going to limit your range of motion. And so how does a patient present who has bad arthritis? Usually you'll say, oh my gosh, Dr. Callander, I have difficulty getting in and out of a car. I have difficulty getting up from a chair. I can't put on my shoes and socks. I can't stand for an extended period of time. I can't run quickly across the street. And so the question is, well, what should I do? Should I get my hip replaced or should I continue to get injections? Should I do physical therapy? My answer is, if you get to a point where you find that your hip has reached to has limited you from keeping up with your friends and doing the things you want to do, then you have really reached the point like, okay, it's time to get it fixed. Because why wait? You don't need to wait. In the old days, we would wait. We'd say, you know, the hip replacement's only going to last for maybe 5, 10, 15 years. You don't want to have to do it over and over again. I've got good news for you. When you have a hip replacement done, it's going to last up to 30 years. Studies have shown 25, 30 years, you're going to have a hip done and it's going to last. And why is that? It's going to last because of those 3 points that I just spoke about: the design, the material, and the techniques. Those 3 things play a big role. And I'm going to touch on that as we move forward. So here's what a classic hip replacement looks like. This is the traditional hip replacement. If you look to the left of the screen, you've worn out the ball and socket, the ball is taken off, and then you end up having a stem put in with a ball and a liner and a socket, and you can see that here. And so in the old days, what we used to do is we would cement in the stem and we would cement in the socket. Well, as you know, when you use any type of caulking mechanism, it will loosen or wear down over time. So we've eliminated cement. And now what we do is what we call a non-cemented stem. And it has these little beads on the stem. And these little beads allow for bone to ingrow. Okay, we call that hydroxyapatite or HA coating. And that allows the bone to grow into the stem. And that's fantastic because now you put a stem into a canal, and instead of cementing it in and that wears over time and the stem loosens, we now have a stem that grows into the canal and the bone grows into the stem. And now that's a single unit. And that allows for a much longer lasting stem. You don't have to worry about it loosening. Now, the other nice thing about the material is that we use ceramic and we also use a high cross-link polyethylene. These 2 things working together allow for a low amount of wear. We don't want a lot of wear because that's really the surgeon's pariah. We don't want to have to come back and say, oh, I'm sorry, Mr. Smith, but I put your hip in, but it's worn out. You don't want to hear that. You want to be one and done. You get this hip in and you're ready to go. And so again, that type of material has really jettisoned us to be able to advance the technique in getting a hip done. And then the third is the technique and how we put the hip in. Again, it's a minimally invasive technique. It allows for a smaller incision. And when you have a smaller incision, less blood loss, quicker recovery. Now, there's different ways to do hip replacements. You can go through the back or the posterior, we call it, or the traditional approach. And then there's the anterior approach. You probably have heard, if you've been doing research on hip replacements or you think you need a hip replacement, you probably heard, oh, some people say you should get it through the front or you should get it through the back. Both are good options and both have their pros and cons. I tend to do more of my patients through the front than the back. And the reason is we've seen in the literature and through studies, it's a quicker recovery. It's shown that you have a better stability, a little less risk of dislocation through the front than the back. Improved accuracy as well with leg lengths and positioning of implants and so forth. One thing you have to know, and I brought up leg lengths. You don't want to have your hip replaced and have one leg longer than another, because if that happens, then you'll walk in a circle, or you might do well if you're standing on the side of a hill. But we don't want that. We want your legs the same length. So we use special tricks and techniques so we don't have that. Now, sometimes we may purposely make it a little bit longer than the other because your anatomy dictates that, because you perhaps have a deformity or loosen in the hip. So we may make you just a little bit longer to stretch you out so it's tight, because it's more important to have a hip that is stable instead of coming out than to have it off by a little millimeter or so. but you just have to understand that orthopedics is an art, and our goal is to make you have a functioning, long-lasting joint replacement. So the final thing I want to say about anterior hip replacements is you also have fewer hip cautions, as I say here at the bottom. You don't have to worry about your position as much after an anterior compared to a posterior. So given the fact these are some of the 4 things I like about anterior, and I do these the most, I want to proceed and give you a little bit more background of the anterior. But before they do that, the one point about the posterior is very good to use if you need a hip revision, or you may have a bone deformity that requires a posterior approach. So this is something you'll decide with your surgeon, and your surgeon will tell you what they think is best and what they're comfortable with. Okay. If we look at the approaches, you'll see that the standard posterior approach, as you can see on the left of your screen, is a longer incision compared to the anterior approach. You can see where it's positioned. And we're able to get in and out. And this is a picture in the operating room where we've sealed off the area where we work. And we have all these, the blue is all sterile coverings that we use. And we are able to get our instruments through a very small incision. And that's unique because we use these special techniques, but we also have special instruments that allow us to sneak in and sneak out. Again, smaller incision, quicker recovery. The things we look at when we get in there are all these little structures. And that's why when Sean was telling you in the beginning, you know, Dr. Callander went to school and then med school and fellowship. That's why we have to go to school for so long, because we got to learn where everything is. And so I'm showing you here, these are special vessels and nerves that lay across the hip joint that we are very careful not to irritate. Because if you do, you can end up with some irritation, with some numbness or pain or bleeding. And so your surgeon, who is fellowship trained, understands all this. And that's why I show that to you, that this is the anatomy that we're working with. So let me show you a little bit. I have a video here of what it looks like doing a anterior hip replacement. We make our incision right in the front of the hip joint. And this video shows you where the muscles are. And the nice thing about the anterior is we don't cut any muscles. We just pull them apart. So we've come through the skin, and now you see the muscles, and I put retractors in here. And here's what it looks like. And you'll see this is the capsule. And so we incise the capsule so that the joint is loose. Then we line up with an instrument to show us where to make the cut of the head. And this is also done under x-ray. So we know exactly where the cut needs to be done. Again, so your leg lengths are correct, the stability of the joint is correct. And we make a little pie cut and that removes out. And now we have clear exposure of the femoral head. And then this is removed with a corkscrew and taken out. Now look at my exposure. I have perfect view of the socket. So here's the socket. And the socket now allows me to use this device, what we call a reamer. And this reamer takes out any of the remaining cartilage, but also reams it down to a smooth surface. So as you can see, one of the reasons I love orthopedics is carpentry. And I get to use all these toys, and I can go in, and I'm pretty much, I'm your carpenter for the day. And I come in, and I'm going to work with your joint and smooth it out, and then put together this little cup that's tapped in, and you can see it. And that's the first part. Now we're going to work on the second part. We have these special tables, which is what we call a Hanna table, and it allows me to lower your leg so then I can bring your femur or your thigh bone up. So watch this. Well, I'm pulling the muscles apart. Again, we don't cut the muscle. I'm lowering the leg down, and you'll see that the bone will pop up and give me exposure. Now, with you, and again, remember, you're completely asleep during all this. You don't notice or hear a thing because your legs are asleep, and we give you medicine that allows you to take a nice nap. So I'm using a hammer. Yes, we do use hammers, and we go tap, 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 and we're going to take out a little slice of the bone that we call it's really the bone marrow. And now the canal is opened up, and we broach it. And we broach it to your size. And you have to remember is that we're all made of different sizes and shapes. So when I come to the operating room, I have all sizes and shapes of trials to use. So I tell everyone it's like going to the shoe department. I've got all the shoes there. I got A, B, C, D, and E, 1, 2, 3, 4, 5. And so that's what I'll have. So I'm going to measure out the size. Once I have the right size that fits, Then I'm going to have them pull that size out and we put it in. So this is a little reamer that we use. That buffs the bone to make it nice and smooth. And then we're going to cap it with a head, which is going to replace what you had. So we reconstitute the hip joint with the ball and the socket. So now I'm putting it back together, and now there you have it. And there's the x-ray picture showing the exact position. So now I can move your hip around on the table and I can see that it's nice and stable. It's not going to come out. And at the same time, I also can check the leg length, make sure you're nice and even. So that kind of gives you an idea of how we go about putting a hip replacement in. So I hope that's clear, but definitely a benefit with the advanced technology. And another thing is that you'll see that we wear these big spacesuits, and the spacesuits are there for us to protect you from infection. The last thing you want is to be in a room where you're at high risk of infection, because you do not want a joint to get infected. And I want to touch on that for a second. One of the wonderful things about Sutter is that we have specific rooms for orthopedics, and these rooms are designed in such a way that it does not allow for infection material or things come through. We have a very closed section, and only certain people are allowed in and out. We wear special spacesuits, and all that is done for one reason only, is to protect you and make it a very safe environment. And our infection rate is less than 1%. Why? Because you're at a facility, it's small, it's designed for these elective procedures. You're not going to a big institution where we're floating in infected, joints or a gallbladder or something like that. It's specific to orthopedics in this area of the hospital. So very important to understand that. So moving forward, here is a patient who is in her 80s, and she has getting up independently from a chair with a walker. As you can see, she's in a horrible amount of pain. I'm kidding. She's absolutely no pain. She's just been taken 2 Tylenol, and she has just gotten up independently on her own, walked back and forth as I showed you. Guess what? She is only an hour and a half out from surgery. So she has already returned to her private room, and she has shown us how she can get up on her own after surgery. So this is pretty exciting stuff. We didn't do this in the old days, but now you can see what a difference it makes. Why? Remember that we did a regional blocks. We just put her legs to sleep. So we have to wait until the nerves come back, and then they can get up and start walking. But she's not going to have the nausea, vomiting. The pain is well controlled. And as you can see, she's independent. And that's what we want. We want you to be independent. And so remember, when you come to Sutter and you're going to set up your appointment for your hip replacement or your knee replacement, you're going to meet with a team that's going to talk to you about your home and who are your caregivers, how is it going to work, who's going to be there to drop you off, pick you up, who will help you at home, what's your home look like, how many rugs do you have. We go through all of this so that you're very comfortable and that we understand what it takes to make this happen and make it perfect. So you come to camp and you go home. All right. Next, I want to touch on a specialty in hip replacement that we use as an alternative to the traditional hip replacement. It's called hip resurfacing. This is a type of hip replacement that I specialize in. Actually, one of 5 surgeons that we do the most of in the United States. I do most of them in the Western United States. And I was trained in England, and it's a design where the ball and socket is reconstituted, but it's done in a certain way where we preserve a lot of the bone. And we do this for a very young, active male. Now, I say male because they're really the only candidates that can have this. Females cannot, because unfortunately, women are designed in such a way that the bone gets a little thinner as we age, whereas males, they stay a little thicker until later in life. And so hip resurfacing falls with males only. Also, it really is only for the patient who unfortunately gets arthritis at a very young age. I have patients in their 20s, 30s, 40s, and even, as you know, in the 50s, who get arthritis to the point that they can't function, and they end up having very limited lifestyle because of the hip pain and limited range of motion and so forth. So this is a perfect option because it's really a bridge. You can have a hip resurfacing done, and then that will carry you on for 20 plus years. And then if you need to convert to a hip replacement, you can, in a very simple fashion, as if you're getting a hip replacement done for the first time. But it's also a wonderful option if you're very young, active male, because you have a larger head, you keep your bone stock, and you can return to a very active lifestyle. So you have increased stability, active lifestyle, and it's really for the 65 and under. Okay, not everyone's a candidate as well, because if you have a poor bone stock, let's say you have avascular necrosis or you have an infected hip, you would not be a candidate for this. But it's a wonderful option, and it's a terrific bridge for those who get a hip replacement at a young age, so they can convert later in life to a standard hip. Because if you have a standard hip early on in life, that will eventually wear, and you have to convert a standard hip to another standard hip, you have the risk of more bone loss. So this is a very good option. So this actually in Birmingham, England, is where it was designed, and Derek McMinn is the leader in design and hip resurfacing that I use. And here I am in England where we did our training. So let me back up and show you a video of what it looks like. So here's the standard hip, okay? And as we said, you have a stem that goes in, replacing and making you the ball, and then you have the socket. Okay, so this is the traditional hip that I told you about. Now let's show you what a hip resurfacing or what Birmingham hip looks like. We put a socket in just like we did for a standard hip, and this is what it looks like. But instead of cutting off the neck, we are resurfacing the neck. And when you resurface the neck, you preserve it. It's like we mill it down and we cap it like a tooth. So think of it this way. When a standard hip is like a root canal, whereas a resurfacing hip is like having your capping your tooth. And that's the difference. Okay, and I have an example here again of what it looks like with the ball in the socket. And you can see the standard hip, and that moves forward just like I showed you. Here's an example of a patient who's 28. He's 6 weeks out from a hip resurfacing. Very active, wonderful option for somebody who is young and active, like I told you. Here's another patient in their 40s, 2.5 months out, doing some kite surfing. Here we are with a hip resurfacing. You can take heavy impact at your own bone stock. Wonderful option. This other patient is going to tell you a little story. He's in his early 60s and a skier.
I feel like I can ski like I'm 30 again. So it's skiing has become just a real joy. My overall health is improved. My movement's improved. I have absolutely no pain. If you'd asked me if I would do it again, in a heartbeat. I just wouldn't have waited so long.
And that is sort of the classic story I always get from all our patients who have hip or knee replacements who are in so much pain for so long. They always go, oh my gosh, I wish I had done this sooner. So again, there's an example of what hip resurfacing is all about. Okay, so we've talked about hip replacement, the posterior approach, the anterior approach, the hip resurfacing. So now let's talk a little bit about knee replacements. And so we'll move down to the knee. And I love this. One of my patients gave me this, which was, are you sure you want to fix your trick knee? This is pretty cool. And, you know, the knee is tricky. It's got a lot of moving parts. And so it's not just slamming a new knee and away you go. You have to really, the knee has gone under a lot of research and studies and designing it, because it's not just a hinge joint, but it's a rotating and hinge joint. And I'll show that to you. But the bottom line is that what we're looking at is the same concepts that we looked at with the hip replacement, where you have wear and tear in the joint. Again, the analogy of the car, you wear down the tire, you're riding bone on bone, and it causes a lot of pain. So how do we deal with it? Well, and how are we advanced here at Sutter to make it a quick recovery? Again, shorter surgical time, decreased blood loss, and the risk of clots have decreased considerably. Let me touch on that for a second. One of the risks of having a joint replacement is the risk of clots. So what we do is we do put you on a blood thinner, and there are different kinds of blood thinners that we use, and we choose the one that's appropriate for you. And by putting you on that limits the risk of a clot, because you don't want to get a clot, because then that can lead to other complications like pulmonary embolisms and things like that. The risk, by the way, is less than 1%, but we take every risk 100% and make sure that we eliminate that as best we can. So one of the ways we minimize it is with blood thinners, but also having a shorter operative time limits the risk, okay? Also, by getting you up and moving right away. You will find that when you come to the hospital and you have your joint replacement, right afterwards, you go up to your room and you're going to get up and walking. So this is Camp Callander. You are not sticking around and sitting in bed. You are going to get up and get going. There's no sitting around. And by getting you up and moving limits that risk of forming clots. Okay. The other thing with knee replacements is we're able to make the knee last longer because we have improved the overall alignment of the knee. Improving the alignment of the knee allows for less wear. So again, when you get your car tires put on, you want them aligned. Why? Because if they're misaligned, you'll wear one side or the other. So we have little tricks to minimize the risk of wear by having them better aligned. Also, as I told you with hips, the material, the design, and the techniques have improved considerably over the last 10, 15 years. And doing that has allowed us to improve the overall implant survival. So again, with knees, we're seeing 25, 30 years survival rate. So if you get your knee replaced, it's one and done, especially if you get it done in your 60s, 70s, okay? And I already talked to you about the minimally invasive approach, where we make a small incision and we minimize the trauma to the soft tissue. You also have to remember, not only is the minimal approach just about the incision size, but it's how we treat the tissue under the skin. By sneaking in and sneaking out and having less trauma to the soft tissue allows for less pain, less blood loss, quicker recovery. Okay, so we have a theme here. So let me show you this video. This shows you kind of the mechanics of the knee. And the purpose is to eliminate the pain where you have that bone-on-bone contact that we see in the knee joint. We want to improve the motion and eliminate that pain. So the designs, the material, and the implants and the technique are very important. So here's a knee going back and forth, and I said it's like a hinge joint, but it also rotates a little bit as it goes back and forth. And so we're going to resurface that joint. We want to take away that area where it's bone on bone. To do that, we're going to really cap it like a tooth. You're going to cap the femur, and you're going to cap the tibia, and you're going to put a little plastic in between. Some people say, oh my God, Dr. Callander, are you going to cut off my leg in the middle and put a hole? No, not at all. All we're doing is we're shaving off the bad bone. Here is a computer model showing that flexion, rotation aspect, and we're going to shave off that bad arthritis, and then we're going to cap it. It's like going to the dentist, and we cement these on, okay? There are some new techniques too now where we don't even use cement. We just have it fit right on there. And so by doing that, we're able to maintain the joint by preserving the ligaments, but just replacing the surface. And you'll see these two options with the right and left. The black material is what we call oxinium. It's a zirconium that's oxidized, and we call it oxinium. And it allows for less wear. Remember when I told you about in the beginning, we do not want to have wear in the joint. If we have wear, what happens? Materials go and get smaller and smaller, and we got to come back and say, okay, Dr. Callander, we got to replace this. I don't want that. We want a high cross-link poly that has a low wear rate in combination with this hard material, which we call oxinium. And what it is, it's very smooth like ceramic, but we can't use ceramic because if we use ceramic, it would break. If you drop a ceramic pot on the ground, it breaks in 1,000 pieces. So what we do is we take like steel and we oxidize it, and it makes it as smooth as ceramic. So now you have a really solid ceramic. It's nice and smooth, and it will last longer. Okay, so what's new with knee replacements? One of the things is this patient-specific instrumentation. And what I'm talking about here is really the concept of using robotics, okay? So if you come to me and you're saying, okay, Dr. Callander, I want to get my knee replacement. We've decided, okay, we're going to replace it. One of the things we're going to have us do is we're going to get an MRI of your knee, and we're going to get a long leg x-ray of your knee. We take those two pieces of data and we put it into a computer. And the computer will identify the areas of your joint that are worn down and how we can best align it so it's perfectly aligned. And it's going to make a customized block with 3D printing. And these blocks are here on the ends of the knee. And so I use these in the OR. So before you come to the operating room, I will design these custom blocks and they will show up. So it's kind of like coming to the OR with your homework done. Instead of having the robot in the OR, I've already used the robot ahead of time. Okay. So what it looks like is this. Here is this plastic that we use. It's a custom cutting block and it fits only to your knee because I've used an MRI and a long leg x-ray to design it. You can see it fits exactly to the end of your femur bone. This is a thigh bone. And so we fix it in place and we're going to use a saw to make the cuts on the end of the bone that need to come off that have the arthritis. But they're doing it in such a way that we know the exact amount of thickness, flexion, extension, rotation, all of those are incorporated on both ends of the bone. Here we're doing it on the tibia end. Again, we fix it in place. And then I'm going to come in with a saw and I'm going to make the cuts after we fix it in place. And then once these cuts are done, we're going to have the exact amount that's needed so that when we put the real implant on, they'll be aligned specifically. And I bring this up because remember, we are not touching your ligaments or anything like that. We're just touching the ends of the bones where the implant are going to go on. And so those ligaments are preserved and they maintain what we call a flexion extension gap where the knee is balanced from side to side and up and down. So you don't want to stuff the knee if you make it too thick in there, it won't move. So it's a real balancing act and it's an art that, you know, when you have a surgeon who's fellowship trained that we have here at Sutter, they're going to know how to do this and make it perfect. So it's nice and balanced and you have a good outcome.
Well, the surgery itself was as easy as it could be. The knee is fine. It doesn't hurt at all when I play golf. I'm just sorry that the knee couldn't fix my golf game because I'm getting too old to play effectively anymore.
There's a sweet patient of mine, and she's now playing golf. When she took this video, she was about 3 months out from surgery, and she's loving her knee, got her range of motion back. It's balanced. She's now going up and down stairs, and it just made her day because she was in so much pain. She couldn't do the things she loved in life. And so that's why we do this. And she can keep up with her friends. And it just, you know, remember when you get your knee replacement, it's not only about the knee and the joint, fixing the joint, but it's the whole body. I mean, your psyche changes. You're not depressed. You don't have any pain. When you have pain all the time, you get depressed and you're limited and you get, you know, angry. Now you can't do the things you want to do. So here's a perfect example of why it's so great to have your knee replaced when it's time. Okay, so a couple more things I want to talk to you about with knee replacements. There's the partial knee replacement, and there's also one called patellofemoral replacement. I'm just going to talk about the partial knee replacement. It's the same concept, but of a knee replacement. However, sometimes you may end up having just a part of your knee worn out. So we don't have to replace the whole knee. We can replace to the inside, the outside, or what we call the patellofemoral, which is where the kneecap goes back and forth at the top of the knee joint. That area, we can just replace that. It allows for a quicker recovery, obviously, because you're not, you know, having to take out all parts of the surfaces of the knee, but it also allows you to return even quicker because you know, an active lifestyle, because you're not having, you know, as much trauma and less need for rehabilitation. So less invasive, maintaining that natural knee function. And again, I'm going to show how we use robotics. Now, one thing I do want to touch on, and that is, as I said, when you come to a Sutter facility, Novato, San Francisco, CPMC, at the Mission Bernal campus, you will have a physical therapist that will be working with you with your hip and knee replacement immediately when you get to the floor. You are going to get up and you are going to walk and you're going to get yourself feeling comfortable and confident. And so that when you are done with physical therapy, if it's 1 day, 2 days, you will be able to get in and out of bed on your own. You'll be able to do stairs on your own so that when you go home, you'll feel confident and that your partner who helps you will feel confident knowing that you'll be able to get around. So you're not going to be on lockdown. You're going to be able to get home and move around. You may even we may design it for you to have a therapist come to the house and work with you a couple times a week, and then you'll do outpatient therapy. Know this, knee replacements, they hurt more than hip replacements. So when you have your knee replaced, it's going to be a little more swollen, a little more stiff, whereas hips, they move a little bit more. You probably have friends that have had both and they say, oh my gosh, the hip was great. The knee hurt a little bit more. Well, that's true. So to be completely candid, knees do hurt a little bit more, but they're better than they used to with the multimodal approach, where we use a lot of injections to keep your knee numb for a longer period of time. We can control the medicine that you get, again, allowing you to get up and get moving and controlling the swelling and so forth in the knee joint. So getting back to the partial knee replacement, when we replace the knee and we do a partial, same concept of a total knee, but just one part. And here's an example where you can see the inside of the knee joint is worn out, but not on the outside. So all we need to do is replace the inside. And that's what we're showing here. We're showing that we just put the implant just here and the rest is left alone. The ligaments, everything are left alone. So as you recall, some way back when, some of those, from Lost in Space, this is what a robot used to look like.
Warning, biophysical experiments extremely dangerous to Earth people.
And that guy, well, he's come and gone, but now this is what a robot looks like in the OR. He doesn't talk to you like that and swing his arms and legs around, but he looks like this and shows you on the screen exactly where we're going to take that area of bone and remove it and replace it with an implant. And so what we do is we use this handheld device that you could call it a robot, and it will understand, once we put all the data points in, how much of the cartilage needs to come around. You'll see at the end, there's a little bead that goes out and in. And so you literally just hold this up to the bone and the computer will guide you and tell you how much bone that needs to be taken away. And so this gives you sort of an idea of the amount that needs to be taken. It can't go too deep, can't go too shallow. And we do this process in a small approach and make these little holes above and below to hold the implant. And then here is an example of the implant that we cement in place, and it lays in the top and the bottom. And then once that's done, there you go. You have the knee replacement with just one side. So that's what we call a partial. Again, this can also be done under the patella, or it can be done on the other side of the knee. Okay, so moving on, why would you want to come to Novato or Sutter to have your knee replaced? Well, I've alluded to this a couple of times. One, it's an elective procedure. You want to do it at a facility that is specifically designed to take on this type of procedure. They're designed in such a way that they have an advanced certification. They have facilities that are up to date and state of the art, where you have private rooms, new facilities, but also a team that works with you from beginning to end, from soup to nuts. They know you, and you're going to have a wonderful concierge approach. And we see that now in our follow-up studies. We've seen in the total hip functional outcome scores and knee, the patients are very, very happy with their results. These were studies back at 2017, 2019, 94%, 80% for hips and knees. Again, knees hurt a little bit more. So not everyone says 90%, but they're now even higher when our latest studies. And it's because they love the fact that the attention they get. And again, you can show up, have your hip or knee replaced and be home for dinner. And so that's what we love about this place. And that's why surgeons, including myself, love working at Sutter, because it really is a great place to work. The staff, we all get along great, and we're all know what we're doing, and there's no question mark. And it just makes for a fantastic atmosphere and exciting place to work. And so I want to share with you this next video is one of my dear patients who wanted to share a testimonial, and it really shows why I'm so grateful that I have this opportunity to do this field of work in orthopedics. It's a true art, and it's a wonderful opportunity, and I'd love to share with you. So it's a great video this gal sent me, and she loves to scuba dive and sent me this. And I just thought it was classic. And this is why we do what we do. We want to improve your life and make sure that you can do the things you want to do. So on that note, I'm going to end here and open the up for questions. I'd love to answer. And Sean, you're on to lead the way.
Great. Well, thank you. What a great presentation, Dr. Callander. You can stop sharing your screen, and we have about 35 questions on tap, and let's see if we can get through some of these. We just want to remind everybody too that you can also still use the Q&A button at the bottom and ask a question by typing it in, and Dr. Callander will answer it for you. So let's get going. The first question is, can you comment on the effectiveness of turmeric?
You know, some patients come into me with different types of medications and ask me, well, does this work? Does that work? If it works for you, use it. I have no problem with it unless there's, side effects from that concerns me, especially from a post-operative standpoint. But turmeric, I've seen some benefit with that. And so I don't regularly prescribe it, but if it's something that you've used in the past, I would suggest continuing to use it. Some people enjoy it for pain relief, control of swelling, and so forth.
Great. Thank you very much. Next question is, what are the risks of hip or knee replacement for people with lower extremity lymphedema?
Well, I mean, if you have lymphedema and you're going to have your hip or knee replaced, before we do anything, what we would likely do is have you meet with a vascular surgeon to make sure that you have good vasculature, because you don't want to compromise the vasculature that you have that may already be limited. And so when you have lymphedema, which is swelling of the legs and poor circulation, I will have a consult with a vascular surgeon to make sure that you're clear. And if they're clear, then we can proceed.
Thank you very much. Next question is, if NSAIDs don't help, what's the next best pain medication?
Great question. You know, also one thing I want to touch on, NSAIDs is a good option, but don't take it too long and at high doses, because it has risk of causing ulcers and things like that. And you definitely don't want to take it if you're on a blood thinner, because that is contraindicated. I would suggest trying Tylenol. Okay, you don't want to take too much Tylenol. We like to limit it between 2 grams, 3 grams a day. But again, these are meds that you want to review with your primary care physician. But there's some other meds such as tramadol. You want to really stay away from the oxycodones, the Norcos, the Vicodins, because then you can be stuck on those for a long time. So usually, physical therapy, ice, anti-inflammatories, medication, and sometimes the injections help.
Great. Thank you very much. Next question is, I'm a very active 61-year-old male, moderate arthritis in both knees, managed with 2 to 4 steroid injections per year. I've seen recent research suggesting steroid injections accelerate deterioration. Will it complicate subsequent knee replacements if I continue steroid injections for several years before knee replacement?
Great question. I tell patients steroid injections, you really want to limit it to 3, maybe 4 a year. Okay. Once every 3 or 4 months is fine. And if it works, great. It's not going to last, but if it's working for you, continue. Now, you already have arthritis. So if you're getting these injections and you're worried, oh, is it going to make a complication for the surgery down the road? It's not, because the whole idea of fixing your knee is to replace it with a new implant that's going to replace what's worn down. So I would suggest, if those injections are working, stick to it. Eventually, I anticipate they will stop. And when that happens, that's when you'll get the joint replacement. And it will not cause any problem when it comes time for that joint replacement.
Great. There are a bunch of questions about stem cells injections, PRP, and other lubricants. You want to address those?
Yeah, great question. I did not touch on that in the talk because it is a whole nother talk. But let me tell you a couple of things. One, in regards to lubricants, first there's the steroid and lubricant that you can put in, and that really gets the inflammation down. It's short-lived. There's also what we call visco supplementation. There are different types of visco supplementation. You may have heard of Synvisc. You may have heard of Euflexa. And these different injections are like a hyaluronic injection. It's like we're trying to make something that's similar to the synovial fluid that you make in your joint. And so there's some natural design fluids that actually come from the rooster's crone. And that protein is what makes up this hyaluron. And so we have found, and it's actually, I think they had initially seen this with racehorses, that they would inject their joints, and they would do greater, do much better. So humans go, whoa, let's try it on us. And so they would try it. So there are various studies that have come out. The Canadians have had one that's sort of a 60-40 success rate with these. So what the Academy of American Orthopedic Surgeons and I myself do is like, you know what, can't hurt to try. You can, what the injection is, it's a single injection, do it once a week for 3 weeks, and you can do it once every 6 months. But I call it motor oil, really. You're getting in there, you're putting this fluid in, and sometimes it works. For those of you who are bone on bone, it's not going to work. It really isn't. You got to remember, the door frame is bent, and if you're going to open and close that door, it's just going to continue to rub. Now, think of it like WD-40, and you're putting it in and it kind of smooths it out for a while, but it's not going to reconstitute a new door. It's not going to make your joint new again. So understand that. So that's an option. Stem cells, PRP. PRP, platelet-rich plasma, is an option in joints. People have seen some success with it. Again, what makes it feel better is you're putting your platelet-rich plasma into your joint. You get a response that your body goes, oh, there's something new, and then an inflammatory response occurs and it makes it feel better for a while. Not going to make cartilage. It does not make cartilage. Okay, you can read everything you want out there, but we cannot make cartilage with PRP. Same with stem cell. We are not injecting stem cells into a joint and forming a new cartilage joint that is going to be pristine and new again. We're just not there yet. The research is still there. We're still working on it in the labs, but go ahead and try the stem cell. I can tell you all my patients have done stem cell, show up in my office going, oh my gosh, I spent thousands of dollars on stem cell, and it helped for a little bit, but not really, Dr. Callander. And you look at the x-ray and you're bone on bone, and it's like, so you can do the math, but I would continue with the conservative approach. I think that is really the win in the game.
Very good. Next question is how does poor bone density, osteoporosis, affect hip and knee replacement outcomes? Is there a point that you are not a candidate?
It's rare that someone's so osteoporotic that we can't do it. Remember, you're the surgeon, who is a fellowship trained joint replacement surgeon, understands that. And we look at your x-rays before surgery, and we actually categorize your bone as type A, that's really good solid bone, to type C, which is poor osteopenic osteoporotic bone. So we know that going in. And so we have special techniques that we do in the OR for hip and knee replacements, where we're gentle with the bone. We may not do a non-cemented, we may use a cemented technique, so we don't hit hard on the bone, but you still can get a knee or hip replacement with osteoporotic bone. But we just take different steps to make it happen and make it a successful outcome.
Great, thank you. The next question is, I had my knee replaced 3 years ago. I cannot put my knee on the floor because I still have some pain. Is that normal?
So I assume this is kneeling if you can't put it on the floor after your knee replacement. And so it's not unusual that you still have some sensitivity over the top of the knee joint where the incision was. And that can take a while. Sometimes it always persists. Maybe you use a pillow or something. But know that if you put pressure on a knee replacement, you're not going to break it. It will hold it solid as a rock, but it may be sensitive.
Great, thank you. Next question is, what is the risk of allergic reaction to chromium implants when one has a nickel allergy?
It's something that we watch closely, but the risk is very low, and we'll test for nickel allergy. And if you do have it, we use materials that don't have the nickel. Okay, so For instance, instead of using the cobalt chrome, we'll use a ceramic or the zirconium, but there are ways to get around that, and we're sensitive to that. And so you'll have some skin tests. If you have that, the surgeon will work with you, and we can pick materials that will work.
Great. We have a couple of questions about chondroitin and glucosamine. You want to address those?
So again, chondroitin sulfate, keratin sulfate, those are all materials that make up the backbone of chondroitin sulfate, glucosamine, okay? So that's part of the aggregate that makes up of it. So when you go and you take glucosamine, you're taking a tablet that has a little keratin sulfate, has a little chondroitin sulfate, which is part of the cartilage, articular cartilage that's in your joint. So your joint is made up of two cartilage, especially in the knee joint. You have a type 1, which is that hard cartilage, and then you have the rubbery cartilage called type 2. And so that articular cartilage is made up of those components of keratin and chondroitin. And so we're just feeding the cartilage. We're making it a little healthier, but you can't make cartilage when you take that. It helps out with overall mechanics and the makeup of the cartilage.
Very good. Thank you. Next question is, what are the risks of knee replacements in patients with well-controlled diabetes, an A1C of less than 7?
So great question. We really have a cutoff. If your A1C, which is your level of your average sugars, is above 7 and 7.5, we really tend to say, look, let's not do the joint replacement until you're below 7. And the reason is multiple studies have shown that you're at a higher risk of infection if you have higher sugar levels. So with the diabetes, I tend to tell my patients, look, you got to get that number down. This is an elective procedure. It's not an emergency. We can work on that with your primary care and endocrinologist to make sure that we get that number down. Also, with diabetics and rheumatoids, you have a little higher risk of infection. So we actually use a special antibiotic cement that always leaches out antibiotics. And that's also another preventative way from getting infection.
Great. Thank you very much. Next question is, I have a meniscus tear in my knee that I think caused my hip arthritis. I was told that the knee did not cause the hip, but a hip may cause the knee issue. Is any of that true?
Well, the song, the hip bone's connected to the knee bone, and there's always a little bit of truth to that. So if you're walking funny and, if you're leaning on one side or the other, does that cause your hip to wear more? I don't know. The jury's out on that. I think the bottom line is you had a meniscus tear, and that is the area that was torn, and you can get that fixed. And your hip is wearing down because it's wearing down and you had some wear in there. What came first, the chicken or the egg? I think you already had some wear if you've got some hip arthritis. It wasn't from that meniscus, but it can aggravate it or make it worse.
Great. Thank you very much. Thanks for all these great questions that keep flowing in. Next one is, I'm a 6-year-old male. I have a 25 millimeter leg discrepancy. Right leg is shorter. Spent 5 years trying to balance my leg length with lifts, but now I have sciatica and many symptoms of arthritis. Any ideas of how I should proceed?
Well, the question is there a leg length discrepancy because you have arthritis in the hip? So you've worn down the hip. So think again, car analogy, you've got a flat tire, the car is going to tilt, right? So if the car is tilted, if we replace the hip, we can even you out. All right. So you may have a worn out hip, and that's why you're shorter on one side. So we can put a new hip in, and then that will balance you out and get rid of those lifts, if that's the case. Remember, you can change lengths with the hip replacement. You can't with the knee, because in the knee, you have a locked system of ligaments on both sides. And so that is a controlled distance that can't be changed. Hips you can change. So that's something to review with your surgeon with x-rays and so forth.
Great. Next question is, I'm a 60-year-old male, another 60-year-old male, 60 and play competitive basketball. I have a
60-year-old male.
Yeah, yes, there
That's
you
young.
go. I play competitive basketball. I have arthritis in both knees and they click when I walk. If I replace one or both knees, could I continue to play competitive full court basketball?
Great question. I have patients who have knee replacements, and remember, an implant's an implant. You don't want to go out and just wear it and wear it and wear it because it will wear out. But I have patients who do short jogs, play a little basketball and tennis, swim, golf, all of that. But you also can do some competitive. Just gotta, watch how much you do and follow. And that's sort of a question between you and your surgeon, because he can also look at your muscle strength, bone quality, and give you really a clear picture of what your options are.
Great. Next question is, does Voltaren treatment work effectively and for how long?
Voltaren is an anti-inflammatory gel that you can place on joints, hips, knees. I find it's helpful for a bursitis or inflamed tissue. Everybody's a little bit different. Again, remember, it's a topical anti-inflammatory that can actually upset the stomach if you have too much of it. So talk to your primary care, but it's a good short-term relief, but it's not the one thing that's going to solve your problem.
Great. Thank you. Next question is, if I have pain in both a knee and the hip, where do you start? If they both need work, do they both get replaced together?
Great question. So let's say you have hip and knee arthritis. You always start at the top and work down, because you need your hip in order to get going with the knee. So I always fix the hip and then you fix the knee.
Great. Next question is, what are the pros and cons of other hip replacement approaches besides anterior? That is, lateral approach or posterior approach?
So the posterior is the traditional. The anterior we discussed. So the pros and cons that we talked about, the anterior, it's we don't cut muscle. You have less risk of dislocation compared to a posterior. And you also have fewer post-operative hip precautions with moving your leg after surgery. A lateral approach has also been shown as an option. But again, you do have some hip precautions afterwards and some muscles are cut. So if I were to choose between anterior, posterior, and lateral, and you're a candidate for all three, I would go with the anterior.
Very good. Thank you very much. Next question is, what is the recovery time for knee replacements, and do you do both at the same time? A couple people asked that.
Right. Whether or not, you have to have them both. Should I have both replaced or not? So great question. So if you get your knee replaced, you'll come in, we'll have it done. As I said, after surgery, I get you up walking the same day. You'll either go home the same day or spend a night or two, depending on your pain level. When you go home, you will have a therapist that will work with you. And for the first few weeks, you're going to be sore and stiff, but moving. You're not going to be on lockdown. May use a walker or go to a cane, depending on your age and your strength and so forth. You'll see me at 3 weeks. After 3 weeks, we'll assess you, see how you're doing, and then you'll start outpatient therapy. And I like to do that a couple times a week for about 6 to 8 weeks. But you'll notice every week we'll get a little bit better. And what we work on is range of motion, getting your leg all the way out, an extension, and getting you into flexion. Okay, so those are two things that we really, really work on in controlling your swelling. So you'll feel pretty good at 6 weeks, 8 weeks, and then really good at 3 months, back to doing everything you pretty much want to do. Some people have some aches and pains here that could take a year, but really within 6 to 8 weeks, you're really doing much better.
Great. Thank you very much. We had about 7 or 8 questions that were about weight, overweight, BMI limits for knee replacements. What are your thoughts on that?
Weight plays a big issue. And you got to remember, if you're 300 pounds, you can replace your hip or knee, but these implants are not designed to take a lot of that weight. And also your studies have shown that your risk of complications with that much weight, with the tissue and skin healing and all of that, is a high risk. So we really work on trying to get your weight down. Now you kind of get caught between a rock and a hard place when, well, look, Dr. Callander, I'm in so much pain, I can't move. And that's why I have all this weight. So I need the new knee or hip in order to get there. And I understand that. So everybody's an individual case, and we assess that and look at those options and see what we can do. Sometimes if you have a lot of weight, you might work with gastroenterologist to do some work and then come back to me. But these are all things that you can discuss with your surgeon.
Great. Next question is, what is the average age for people to have knee and hip replacements?
You know, in the old days, no one got their hip or knees replaced until their 70s because they said, oh, it's only going to last for a while. But now we see it younger and younger. And as I said, for instance, the hip resurfacing, if you're in your 20s or 30s and you're in a ton of pain, you can't move, you might as well get a hip resurfacing because you can get up and get going. Why torture yourself for 20, 30 years before you get a hip replacement? So we tend to just put hip and knee replacements in patients who have failed all conservative measures and are of an active lifestyle and they're limited, and then we will consider that as an option. So on average, I'll see, the bell curve is the 60s for hip and knees, but it definitely stretches at both ends.
Very good. Thank you. Next question is, I understand that a partial does not last as long as a total, and it is likely that a revision to a total will be needed at some point, which I understand is more difficult surgery with poor outcomes than having a total to begin with. Can you comment?
Right. It's a good question. Partials can last 10, 15, maybe 20 years and they can wear. Depends again what your activity is. I mean, if you're going up and down Everest every day, yeah, you're going to wear it out. Or you're running and doing marathons, you'll wear it out. But initially, partials were designed for patients, elderly, low impact. Now, patients like to get the partials earlier on in life because it's a quicker recovery and they're designed to last longer. But there is that risk that you need to convert it. So sometimes there's the discussion with your surgeon, well, I just want to do it once, one and done, and you're at a certain age that would work, then you should do just a knee replacement and skip the partial. So this is a discussion with your surgeon.
Great. Thank you. Next question is, I'm early 60s, very healthy and an avid walker hiker. For the first time in my life, I've had hip pain for several weeks after hiking or walking 3 to 5 miles. What type of specialist should I see first? An orthopedist, physical therapist, or something else?
You might first talk to your primary care and give them the story, and they're the best first step. I've got hip pain. This is where it is. They may order an x-ray. They may start you with some physical therapy. And then the primary care physicians know orthopedists that they would refer you to. And so that, I think, would be the best step. Now, if you're someone who, oh my gosh, I've been diagnosed with arthritis, I've tried all the conservative measures, my primary care says I need to see someone, that's when you go straight to the orthopedist who's a specialist in hip and knee.
Great. Next question is, what restrictions remain lifelong after hip replacement? For example, can you go back to riding horses?
Riding a horse, I love riding horses. I'm actually enjoy it. And I tell all my patients who do equestrian riding that it's actually the perfect position for a hip replacement when you're sitting and your legs are externally rotated out a little bit, and hip flexion, it's perfect. So anterior or posterior approach, you're fine with horseback riding.
Very good. Next question is, how long does it take for the bone to mesh onto the stem? Are your activities limited during this time?
Great question. So it is a good 3 months, 3 to 6 months to really get in there and get hard, but we don't limit you too much. I don't want you going and doing jumping jacks and playing pickup basketball within the first, few months. But after that, you can get up and get going at 3 to 4 months and doing more. And again, putting weight on it triggers some bone growth. So there's a fine balance there. We want to do some weight bearing, but you don't want to be banging it and actually loading it hard at first. You got to let that bone coalesce around the stem.
Great. Thank you very much. I hope I don't get this pronunciation wrong, but is it possible to perform a successful hip replacement if I've been on bisphosphonates for a long time?
Okay, so bisphosphonates are medication that people take that need to, they're osteopenic. And so there's a risk with bisphosphonates because your bone can be a little bit more brittle. So we like patients to be off it for a little while. And it's also very important to know that you don't want to be on bisphosphonates straight all the time. You want to alternate in and out, maybe 6 months on, 6 months off, and your endocrinologist can go through that with you, because you can have these what we call atypical fractures where your bone just breaks in half. And I see that with femurs and tibias, mainly in the femur bone in females, because the bone becomes more brittle because these little cells eat up the bone. We call them osteoclasts, to make calcium to get into your system. And when you're osteopenia, it can cause this osteopenia. So very important. That's something to go over with your surgeon, but this is definitely taken into account when deciding timing on surgery.
Great. Next question is, I have had both hips replaced, 2014 lateral and 2020 anterior, and still experiencing some soft tissue pain that limits my mobility from the most recent one. I try not to take NSAIDs routinely because of the potential damage to internal organs. I have had PT and do stretching every day, but still have pain and would love to take one Aleve every day, which really helps both the hips and the knees. Do you think this would be worth the risks? Steroids have not been helpful.
You could do an Aleve a day, but again, this is something you need to talk to your primary care, because you'll be on Aleve in a day for months after months after months. There might be a balancing act there, because and when you are on anti-inflammatories for a long time, it's important to let your primary care know, and he'll probably want to get liver enzymes and so forth to keep a track of you. So that's something you want to communicate with your PCP.
Great. Thank you. The next one says, my wife had a Birmingham hip replacement. I'm not sure why that was done if it's not appropriate for females.
Okay, so when Birmingham hip replacements were done, initially when they were approved, FDA approved, males and females could have it done. And then it was 2016 or 15, there was some research that came out that showed that females have a high risk of fracture and also a high risk of what we call metallosis, because it's a smaller size implant. It's a metal implant. And so there's an uptick in metal wear. And so the feeling is that after that research has come out, they said moving forward, it really should be done in males who have bigger implant sizes, less risk of metallosis, and less risk of fracture.
Very good. Thank you. Next question is, what does the research about robotics show in terms of procedure effectiveness, any risk factors, appliance endurance, and how does it contrast to non-robotic knee replacements?
It's a great question. There's a lot of literature out there. There's the pros and cons in robotics. It depends on which camp you're in. Some people are pro robotics, some are pro traditional. I feel that there's benefits in both. The robotics are great for, specific alignment, as I was telling you, making sure that everything is perfectly placed, and sometimes can allow for a quicker procedure and less invasive. The traditional side also has its pros, and you don't have the time of surgery with setting up a robotic, or the risk of infection with making extra holes to set up the robotic. So there's a lot of back and forth on that, and there's no right answer.
Great. Thank you very much. Next question is, what other treatments can be given when steroid injections do not work anymore? My mom is 98 years old and the left knee is bone on bone.
So that's a tricky one. I mean, we're 98 and, you've worn down the bone and you're bone on bone. And if you have an injection, it doesn't work, then maybe a little physical therapy, ice. I wouldn't recommend a knee replacement at 98. So it's really pain management. If you can tolerate some NSAIDs, tramadol, different meds that your primary care can provide. Maybe some knee sleeves, things like that.
Very good. Next question is, do you recommend ice machines post-op?
Ice machines are great. I don't use them on hips because all you need is just a ice pack to lay on there. For knees, ice packs work well, and also ice machines for knees are very nice because you can just leave it running and not have to worry about changing the pack or moving it back and forth. Different options, looking at costs, availability, and benefits. One thing I do tell everyone though, if you do have an ice machine, instead of filling it up with ice every time, you're going to run out of ice every 6 hours because your freezer's not going to keep making it. So get small water bottles, freeze them, and have 6 of them, and then you rotate 3 in and water and 3 you freeze. So you always can just rotate those through. It's a good little trick.
Great. Thanks for the tip. Next question is, actually, there are a couple questions about meniscus tears and about
Okay.
partial knee surgery. Can you repair a meniscus tear at the same time you do a partial?
So for instance, if one side is torn and you have arthritis on the other, you're going to get a partial. Usually, you may want to fix the meniscus if it's torn and it's clear. But fixing a meniscus when you're older in your 40s or 50s, usually we don't do that. Usually we'll trim it back. It's kind of like a hangnail, and you trim back that tear to a stable rim, and that makes the pain go away. We don't repair meniscus. Usually it's on the young, active, elite athlete who has a quick acute tear, and those can be fixed. You can have, usually if you have a lot of meniscal tears over time, it can lead to arthritis, and that's why you get a partial. But you usually would want to fix the meniscus, then go and do the partial replacement. I wouldn't do it all at the same time.
Good. Next question is, I am 68, and while riding a bike, I experienced some knee pain in my right knee on the right side of the kneecap. Do I need to worry about this?
So probably what you're experiencing is when the kneecap goes back and forth, you can get wear in the kneecap, and it will wear on one side, which is for this person saying it hurts when they ride their bike on the outside. So a couple tricks are work on your quads, getting them stronger on the inside, what we call the VMOs. That helps pull the kneecap in more. Also, when you're riding, make sure you have good arches, or even just when you're walking, you have good arch support. That will bring the kneecap in. And if you're a big cyclist, you may even want to talk to a cyclist pro at a pro shop. They can look at your positioning on the bike, make sure that your pedals are the right distance, and look at your overall motion so that you're not causing too much flexion or too much extension when you do a rotation that can irritate the patella.
Great. Thank you very much. Next question is, what is your suggestion for handling chronic hip bursitis, inflamed hip bursa joint for a person over 50 years old?
Yeah, these are tricky. Hip bursitis, which is inflammation of bursal sac. We have them on our elbows and our knees and our hips and shoulders, and they're there. They're kind of like a ball bearing for the joint, so it moves nice and smoothly. But they can get inflamed, and they get inflamed, it hurts. And so usually you can do a cortisone shot, you do ice, do some physical therapy. I call it kind of the tennis elbow. Every so often your tennis elbow flares up if you do something too much and it gets aggravated. You have to calm it down. Usually surgery is not an option, and I would highly recommend not doing surgery for a hip bursitis. I would suggest the injections, ice, stretching, PT, maybe even that Voltaren gel that we talked about earlier.
Great, thank you. Next question is, does vitamin K2 help bone growth?
Vitamin K2 help bone growth? I'm not a pro on that question, so I think I will pass that on to your primary care endocrinologist. Bone growth, really, when you, let's say you have a fracture and you want to heal your bone, one of the things that happens is if the bone does break, we line it up, make it fix, but we also want to put weight across the bone to stimulate new bone growth. And to do that, there's a thing called Wolff's Law, where you put pressure or gravity, the cells, the osteoblasts form new bone. And that's one way that we see new bone growth. So One thing is elderly people, you always say, we want you to exercise, get out, get your walks daily. That helps stimulate bone growth, especially if you have a history of osteopenia. So that's what I would promote. But for that question, maybe ask your endocrinologist.
Great, thank you. Next question is, I'm 66 years old. My apartment is up 2 flights of stairs with no elevator. With knee replacement, how soon would I typically be able to climb those stairs?
I love stairs for knee replacements. Just know that if I'm going to replace your knee, you're getting on the stairs right away. It will be tricky at first, but you'll be able to get up the stairs because you'll learn that in the hospital. You may stay up there for a little while and have a therapist come work with you and then do days of short stairs up and back. But after, 10 days, you'll be doing them more and more and be able to get in and out. And it'll be good exercise, especially with regaining that range of motion.
Very good. Thank you. Next question is, I'm on Eliquis because of AFib. In a past surgery, a week after the surgery, I had internal bleeding that was incredibly serious. How much of a risk of internal bleeding exists post-surgical in a knee replacement?
Well, we'll take you off the Eliquis for the surgery, obviously, and then we put you back on. So we watch you in the hospital and the swelling and so forth, and maybe have you on just aspirin and then go back onto the Eliquis in a few days, or we put you on a lower dose Eliquis, watch, and then increase the level. So we have a good idea of your swelling. If it swells a lot, then we can always drain it.
Very good. Thank you. Next question is the ACL preserved with a total knee replacement?
It is not. The ACL is taken out. The other ligaments are preserved. So there's 2 types of knees. There's a posterior stabilized or a cruciate retaining. And a posterior stabilized knee, the ACL and the PCL come out. And the cruciate retaining, the ACL comes out and we keep the PCL. And that's just 2 different designs with the knee joint. And it's kind of across the country, it's kind of 50-50 with surgeons choosing one design over the other. They both work very well, but the ACL definitely comes out. But we keep the ligaments on the outside of the knee to protect from side to side motion. And then the knee joint itself has a design that replaces what the ACL does. So no worries that you lose your ACL. You still maintain your stability with the knee replacement.
Great, thank you. Next question is, are there knee or leg exercises before having surgery on the knee that would help?
Absolutely. The thing I encourage patients to keep an active lifestyle, walking, stationary bike, even just swimming. If you like swimming, and then the exercises, quad exercises, doing straight leg raises, lying on your back with your knees completely straight and just going up and down. The other thing are wall sits, where you sit up against the wall and you bend your knees 90, lie your back up against the wall and bend your knees about 90 degrees and count to 10. And that really helps with gaining the strength in the quads, and that will help with their post-operative recovery.
Great. Next question is, I had a microfracture surgery 16 weeks ago and still can't fully straighten or bend my knees without extreme pain. What causes this, and is this slow recovery normal?
Microfracture, for those of you who don't know, is just making little holes in the cartilage in a knee, and that can stimulate new fibrous growth. There's a concept of maybe new cartilage, but it's stimulating growth, and those can take a while. They hurt. And so you probably can't move your knee as much and can't straighten it because you probably have swelling in there from the procedure, because your joint is like a big balloon and it's encapsulated. And so when it fills up, your knee kind of locks and can't move. And when you get the fluid down, then it can move more and have more motion. So that's probably what you're experiencing. Just hang in there, and with time, it should get better.
Great. Next question is, what complications are there for knee replacements in a patient with ACL reconstructions?
So if you've had a previous ACL and then over time it's worn down, no real complications. We address that fine because we do this all the time, and we see patients who've had their ACLs reconstructed. We usually take out the screws, or we call interference screws, that were used, and then we can easily proceed with the knee replacement.
Great, thank you. Next question is, Does a person with arthritis have to wait until their joint is totally bone on bone before they can get the joint replaced?
So that's a great question because everyone says, oh my gosh, I have arthritis. Should I get a replacement? Really, I'll have patients who come in and they have horrible films. They're pure bone on bone, but no pain. And then you have some that have just a little bit of wear and a lot of pain. So again, you really want to exhaust all the conservative options before you even consider surgery. And if you do, and you're still in pain after doing all the conservative options, then you have a heart to heart with your surgeon and say, look, I can't do the things I want to do. I can't keep up with my friends. I'm limited in my function. And you have arthritis, then there's a serious consideration that you will proceed with a knee or hip replacement. But you can also have a horrible looking film, and unless the bone isn't, compromised, you can continue on. You treat the patient, you don't treat the X-ray.
Very good. Next question is, I'm a female who had a total hip replacement 13 years ago. What can I expect as to when I have to have it redone?
Hips last a long, long time. So the best thing to do is every 3 to 5 years, get an X-ray and do that with your orthopedist that either did it or another joint replacement surgeon. It's just a quick check and they can say, okay, they'll examine your hip, look at the implant, make sure it's in well position and it's not loose. Can predict how it's looking if there's any wear. So I wouldn't worry. Just stay active and enjoy your new hip.
Very good. Next question is, I have had surgery to clean up my left knee medial meniscus and was told to stop running, which I did. They told me I could continue to walk with the brace they gave me, and that was okay for a while. But now I'm getting more pain, especially after my walk and trying to climb stairs. It's getting annoying, and I'm not sure what more to do other than using 800 milligrams of ibuprofen. Any suggestions?
Follow up with your orthopedist, get new x-rays, see where the wear is. There's a lot of tricks still that can be done. Sometimes you can use, if it's just on one side and the brace you have, you can do what we call an unloader brace, where you can move the knee and use the good cartilage instead of the bad cartilage, and that can help to control your pain. Maybe there's viscosupplementation injections. Get a lot of options. Follow up with your orthopedist, get new films, reassess, and then decide.
Great. The next question is, my mother had a knee replacement at age 73 in 2004. It was problematic from the start and remains tight with limited range of motion. She is otherwise in great health and now 90 years old. Is she a candidate to have her 17-year-old knee replacement replaced? Would she benefit from a replacement?
I wouldn't. If it's not causing her pain, she's definitely limited, but going in and revising a knee that's stiff at her age is not a big win. You got to look at the pros and cons and surgery and her lifestyle. If it's not causing a lot of pain but stiff, I would put up with it.
Great. Another question is, what to do if knee cracking has just begun? Stretching, foam rollers, and lacrosse ball have not prevented the cracking and popping. There doesn't seem to be grinding and no pain. What is the cracking from?
Well, you have AGE, which is age. So welcome to the club. You're going to hear cracking. I mean, things happen. And as you get older, they'll have little cracks here and there. Don't worry about it. It's not hurting you. Just be active. Stretching is always good. And if you have any concern, you might as well follow up with your primary care, and they can maybe get some x-rays. And if they have concern, they'll move you on to orthopedist.
Great. We'll take a couple more questions here. Next one is, I have a strong tendency to form scar tissue and keloid. Can your approach help minimize this problem post-op?
So that's a tricky one because some people make keloid more than others. And we do a minimally invasive approach. We do close the incision from inside out, and we do a nice plastic surgery closure. But you cannot always control keloids. Some people get keloids. And so if you do, let it heal. And then there are tricks you can do to treat it. Sometimes injections of steroids, things like that. There are different creams that you can do. But that's really genetics. And so there's only so much we can do. But we will do everything we can to minimize that risk of a keloid.
Great. Next question is, How long are knee hip replacements on blood recipients on blood thinners? A short time after surgery or indefinitely?
So all dependent upon your history, but if you're just a standard patient, never had a history of clots or anything like that, usually we'll do 30 days on a blood thinner. It could be an aspirin, a baby aspirin, one twice a day. If you are someone who has a risk of clotting, we may put you on an Eliquis and do that for 30 days. So it all depends upon your medical history, but usually it's 1 month. Again, remember, our hip and knee replacements are done in such a way that it's a quick procedure. We are up, running, and moving right away. And also remember, when you do a regional block, like a spinal, where we just put your legs to sleep, studies have shown that also lowers your risk of getting clots. So all these things play a part and make up the pieces to the pie. But know that we'll have you on blood thinners because we want to eliminate that risk of clots, and we'll get you up and going right away, but only for a month that you usually need it.
Great. Thank you. Next question is, I'm an active 76-year-old male with torn meniscus in 2 places in the right knee and worn away cartilage, so I'm looking at the possibility of a replacement. I also have a pretty large Bacon's cyst at the back of the knee, and I'm wondering if that would automatically get taken care of if I have a replacement.
Indeed. So what you have is what we call a Baker cyst. It's typically found in the back of knees, especially in knees that have arthritis. They form a fluid collection in the back of your knee, completely benign and natural and normal. It will be taken care of in a knee replacement, because when we go in there, we decompress that cyst, and you would do fine and be a good candidate for knee replacement, especially if you've exhausted all conservative measures.
Great. Thank you very much. Next question is, my mom is 88 and bone on bone with her hip. Is she too old for hip replacement? Is there an age that's just not recommended?
You know, I have done patients older than that, and they do great. It all really depends upon their health. And so someone in their 80s or late 80s, early 90s, this is not just my decision, it's a group decision where I will work with your primary care physician or your cardiologist if indicated, and we'll decide the risk benefits. But again, remember that these surgeries are done in such a way that, it's not a general anesthesia. You do a spinal. We can even keep you awake if you want and listen, but usually I give you a little snooze juice and you take a nap so you don't hear or see anything, just like you do with a colonoscopy. But so there's a lower risk than with the big general, and the blood loss is much less. So things have changed considerably, and we're seeing patients in their 80s and 90s getting these done if indicated. But again, it's a group decision of your physicians to decide if you're a good candidate or not.
Great. Thank you. Next question is, I was told that I have knee arthritis, and for that I was doing physical therapy. After I did an MRI, I was told that I have a meniscus tear. Should I stop physical therapy to protect against more damage, or continue physical therapy to keep my muscle from atrophy?
I would follow up with your orthopedist, and they can read the MRI and decide how bad a tear it is. Sometimes you can have a degenerative tear that's just there. We all get meniscus tears as we age. It's just like, the treads on the tire kind of wear down a little bit. Some hurt, some don't. Some move, some don't. So I would follow up with your orthopedist on that question.
Great. Another good question here. 80 years old. How does one tell the difference from sciatica versus hip issues? Stairs and walking are difficult and slow. Also, right knee scoped around 55, but told I needed a replacement. Now I'm getting pain.
Okay, that's a really good question, because there are times when patients complain of hip pain and back pain, and we don't know, well, where's the pain coming from? What's the etiology of that pain? So the way we figure this out is sometimes what we'll do is give a lidocaine injection into the hip joint under fluoro guidance or ultrasound guidance. And if we find that the pain goes away after the injection in the hip, then it's coming from the hip. But if we inject in the hip joint and we find that, it still hurts, then it's not coming from the hip joint. Maybe it's coming from the muscles or the back. So there are little tricks that we do. So those are the things you have to consider.
Great. Next question is, it hurts my hips when I do Tai Chi squats, like a sharp stabbing. when I rotate my feet out. Is this just a flexibility issue or nerves in my hips?
Now, that's the first time I've heard that question. And I'm not a Tai Chi expert. But I would say the best way to understand the positioning and the pain and what's going on is to follow up with an orthopedist and have them do those range of motion exercises with you on the table, explain to them what hurts and what doesn't, and then they can isolate where the pain is coming from.
Great. Another question here. After hip replacement, can I garden with one knee on the ground? I would typically do this for hours at a time, removing weeds, etc.
Absolutely. That's why we're doing it. You can absolutely get down on your knees, get up again. That's the whole benefit of having a hip replacement.
Great. We'll take a couple more.
Okay.
How much time does it take to be able to go back to work as a construction worker after knee and hip replacement surgery?
Well, if you're getting both of them done, then it'll probably take a little while because you got to heal from both. But if you're doing one or the other, the knees take a little longer than the hips. So I would say if you're doing construction, you want to wait. Everybody's different, 2, maybe 3 months for hip, and maybe the same for knee. Depends on what you're doing in construction, what level of activity. Are you going up and down ladders? You're carrying things? It is a desk job. These are questions that you would go over with your orthopedist.
Very good. Next question is, are there any impacts of disturbed bone marrow in a hip replacement?
Disturbed bone marrow and a hip replacement? No, I think, that's totally normal to go in and do the surgery through the marrow for the hip replacement and no complications with that. I think I'm answering that question.
Great, thank you. That's all there was on that question. So,
Okay.
Next question is frequent knee swelling without pain signs of a degenerative joint? When we're told to keep active, how do we know when we're doing more damage than good when there's swelling?
So what's going on is the classic situation. I'm very active and my knee swells. Well, sometimes we call that water on the knee, where your knee swells. And remember, knees swell for a reason. They're there because, through evolution, you want to make sure that we're designed to make your knee swell to slow you down so you don't run out of the cave and get eaten by the mammoth because you can't move very fast because you got a bad knee. So we do these things to protect. They're protective mechanisms. Slow down. Don't do anything. I would say that if you have swelling in the knee and it comes frequently, but it's not too bad, maybe a quick x-ray and follow up with an orthopedist to assess it for you.
Great. Next question is, with a total knee replacement, are there movements that are ill-advised post-op?
With a total knee replacement, no, I want you doing everything. I want you up walking. You can put all your weight on it right away. You don't have to wait for it to heal. The only thing is you don't want to be too aggressive out of the gate because you're still healing the soft tissue. You don't want to be like running or doing long walks. You got to get that soft tissue to heal because it could swell up more. If it swells up too much in the beginning, then you're going to have a slower recovery, regaining that range of motion. So it's a balancing act, and that's going to be your guide will be your physical therapist.
Great. Here's an interesting question. I have osteopenia on the left hip. Is there any reason why I have pain on my right hip?
Have to see the x-rays. Could be that you have a little arthritis. Maybe you've got what we call a labral tear. So the cartilage is torn. The labrum is like the meniscus of the hip, and sometimes that tears. But x-rays are needed for me to clearly answer that question, and an exam.
Great. Well, Dr. Callander, thank you very much. We have some really terrific questions tonight. I'm glad everyone stayed on a little later. We still have a couple that are unanswered, but you'll be able to answer or ask those on the little pop-up form that will come up after tonight's webinar. And if you don't see the form pop up, then you'll get an email tomorrow with a link to it. And then you'll be able to ask Dr. Callander some additional questions, give us feedback on the survey, and schedule a consultation with Dr. Callander if you're interested. So thank you very much for joining us. Thank you, Dr. Callander, for a wonderful presentation and the extra time on the questions. And with that, I'll turn it over to you for the last couple of words.
Well, Sean, thank you. And thank you, all of you. I'm grateful to have this opportunity to share a little bit about my world and the passion I have with orthopedics and joint replacements. And so I hope that all of you learned a little bit from this webinar, and please feel free to reach out. And I wish you all the best and have a wonderful evening. Good night.